a vision co-founded by Dr. Alagappan Thiagarajan Sir and myself, Dr. Hansala Sheikh, with the goal of creating a premium intellectual community for Indian physiotherapists, a space where ideas move, conversations heal, and learning evolves. Through webinars, podcasts, journal clubs, and academic collaborations, we aim to connect evidence with experience, clinicians with educators, and curiosity with creativity. This is the beginning of something much larger, a platform built by physiotherapists for physiotherapists. Allow me to briefly introduce the minds behind Rehab Dialogue. Dr. Alagappan Thiagarajan Sir, MPT Sports, PhD, Sir is a faculty and researcher at Mahsha University, Malaysia. He is also a founder and head physiotherapist at First Step Physiotherapy Clinic Private Limited, India. With over 50 publications, 2 authored books, an extraordinary career in sports medicine, adaptive sports, and holistic rehab, Sir's work bridges the science of performance with the art of recovery. Sir has been an invited speaker to more than 60 national and international conferences and has also been the award holder for an Outstanding Physiotherapist Award by IAP and has been recognized by clinical excellence and leadership disciplines across various universities. And I am Dr. Hansala Sheikh, neurophysiotherapist, academician, nutritionist, and researcher, currently serving as an assistant professor at Sri B.G. Patel College of Physiotherapy. My academic and professional endeavors revolve around neurological rehabilitation. I have contributed book chapters and research publications in multiple national and international journals. I am proudly serving as a reviewer for multiple journals and also as a research writer for Pedro. I have collaborated with NPTEL India for lecture translations. So, together, we envision Rehab Dialogue as a platform that celebrates both depth and dialogue, where knowledge is not just shared but shaped. Today, we are honored to host a distinguished scholar and clinician, Dr. Thangamani Ramalingam Alagappan Sir. Sir is a senior faculty and physiotherapist at the Sarvajanik College of Physiotherapy, Surat. Dr. Thangamani Sir brings over 25 years of rich academic and clinical experience. His pioneering research integrates physiotherapy and psychology, focusing on chronic musculoskeletal pain, central sensitization, and biopsychosocial pain management. Sir has authored 5 textbooks, published more than 60 scientific papers in Scopus and Web of Science Index journals, and Sir holds a commendable record of 400 plus citations with an H index of 9. A passionate educator and translator of evidence, Sir has contributed immensely to knowledge translation by bringing Cochrane summaries and the Pedro homepage to Tamil. His interdisciplinary PhD explores activity pacing, psychological distress, and quality of life in chronic pain populations, a reflection of his vision for holistic pain paradigm. So it's truly a privilege to have you with us today. So let's now begin today's dialogue, that is understanding chronic back pain, theoretical foundations for modern physiotherapy practice. Over to you, sir, for expert insights.
Thank you, Dr. Hansala and Dr. Alagappan. I really appreciate your efforts to start with Rehab Dialogue, a platform to share and disseminate physiotherapy knowledge and practice. Really, it is somewhat more interesting, and it could be a good example for the upcoming physiotherapists in the field. Your leadership really stunning and heart-winning thing. I really appreciate once again. Shall we
Thank you,
go
sir.
into
Thank
the
you. We are
topic?
honored. Yes, yes, for sure.
Okay, next slide. Very good morning to all the audience and participants, my fellow physiotherapy fraternity. First of all, I would like to be very thankful to one and all to have some kind of academic inputs on Sunday morning, and moreover, it is vacation mode for everyone. I really appreciate your academic interest in this regard. This particular dialogue of today's session is regarding chronic musculoskeletal pain, especially back pain, how it is being managed in physiotherapy. And today I'm going to discuss two things with you. My presentation will be somewhat short and sweet. I may be of more helpful to you people with your Q&A session. And the first part of the presentation will be regarding the theoretical background of what is pain and what is chronic pain and where we are right now. Okay. And the next part is that how the physiotherapy practice should evolve into the next stage from the current practice strategies or attitudes, whatever you say. So I have only two parts. To start with that, uh, as all of us we know, the musculoskeletal physiotherapy practice, mostly we spend time in relieving pain only. It's pain, pain, pain. Pain is not just a symptom for the patients, it is the breadwinning thing for the physiotherapist. We always claim that we are pain specialists, pain managers, pain modulators, etc., etc. We have a lot of prefix to add or suffix to add with our names. If you see the chronic back pain, one of the important and very disgusting condition to practice. But when we start with physiotherapy in undergraduate, as an undergraduate student, we think that's very easy. People we are going to treat with some electrotherapy and exercise therapy modalities. We can be very much successful, but the practice experience is not show. There are people, some percentage of people, we could not able to satisfy them with their expectation, especially the pain relief. We could not able to achieve or attain to the level what is the expectation from the patient community. So chronic pain is one of the leading cause of disability worldwide. All we know that. If you see the picture, more than 50 million people are suffering from chronic pain every year. This is the CDC prevalence rate. The second picture, if you see, the light blue color indicates that there are a lot of chronic musculoskeletal pain patients we are supposed to deal, and they have a lot of disabilities to cope up with, to lead their life. Okay, this particular graph is from Lancet. This one, what it indicates is that we have a very big scope, learning further and progressing further in pain understanding, pain theories, where we are, how we are supposed to move ahead, because this is one of the area of scope for physiotherapist. Okay, you can see that chronic musculoskeletal pain. Okay, with that light blue color. Okay, that is the musculoskeletal disorders. So this side, no, it works. So if you see in the picture, our role as a physiotherapist in the health community, health professional practice, no, it's huge and highly potential one. So it's better to learn further about what is pain and how to deal with it. Next slide, please. If it comes to definition, previously we used to define pain which is more than 6 months is chronic pain, which is less than 6 months it's acute pain. The concepts have been changing. It's almost changed. The present ICD 11, International Classification of Disease 11, version 11, and IASP classification and all, they are telling any pain which is persisting more than 3 months can be called as chronic pain. Uh, in that, according to ICD 11, there are 7 types of chronic pains are being classified or categorized. In that, one of the categories is that chronic musculoskeletal pain, which we are very much into that for today's session. The chronic musculoskeletal pain can be divided into two types. One is primary, another one is secondary. The primary is the one which is there within the musculoskeletal system. Here and there, the pain will be there. More than 2 3 sides, pain will be there. It will be keep on shifting the areas, locations like that. The secondary musculoskeletal pain is that it is due to some other cause in some other system. For example, you may be having some problem with your intestinal system, some disease like Crohn's disease. You may be having some kind of musculoskeletal pain. So that is called secondary. So we are not into that. We are into the first one, the primary chronic musculoskeletal pain. Okay. As of all we know, pain is due to some damage to the tissues. This is the old theory. We know that, and we know some pain modulation concepts like gate theory, which we follow. The pain impulse travels through the large diameter fibers. If we give some other stimuli, that will go faster and block the pain impulse. This is what we studied, and we used the same theory for almost more than 2 3 decades. But we have to understand what happens in a chronic pain. If you see the picture, the x-axis shows that the increase in the months gradually making the tissue injury, and there are a lot of other risk factors. Okay, and it makes the pain from the peripheral to centralized. Okay, I will gradually explain how it is becoming centralized. There are many factors which can contribute to that particular this one. Despite the injury heals, the pain persists because of these factors. So if the pain is not treated effectively in the beginning of the time, or if it is having some additive factors to play with, then the pain may become chronic, and it is very difficult to modulate. So we have to know how we can modulate the pain. Apart from the gate theory, what are the other things we have to consider in our assessment, evaluation, and in our physiotherapy management? The next thing concept which we have to understand is that central sensitization. This also I will explain you what happens in central sensitization, what theories talk about that. The third one is that pain memory. It's an important concept which is talking about the higher centers and their role, despite there is no injury to the peripheral tissues. We can perceive pain. Okay, for example, you must have heard about phantom limb pain and all. Okay, so we have to understand how pain memory works, how we can change, and how we have to evaluate all those things in our practice. Next, and the historical overview of the pain theories. Initially, it started in 400 BC. Pain was emotional. Then gradually, it became somewhat physical and mental. There is two different pain, dualistic theory by Rene Descartes. He insisted there are two types of pain. One is physical pain, another one is mental pain, like that. Then gradually we brought the what do you call physical dominated pain theories, like and there are receptors carrying the thing. There is one receptor for pain, there are many receptors for pain. Specific theory, pattern theory, like that. Gradually it moved to gate theory, how the pain is being modulated. Then we have neurometrics model and biosocial social model in nowadays practice. I will get into all these things one by one. So, simple understanding is that the shift from the simple tissue damage focus to multifactorial perspective. So, we are going to discuss about that only. What are the multifactorial perspectives? How we have to concentrate in our physiotherapy practice. Okay, next slide. The biomedical model, all we know that there is a damage, and it directly travels through the channels, pathways. Okay, this we practiced for more than 400 to 600 years, no, from 1662 to almost 1800, 1900. No, we practiced only this model of D. Rene Descartes, pure biomedical model of pain. Okay, but it could not able to explain the persistence of pain without structural findings. Okay, there are a lot of pains mentioned and really treated by the physicians and the medical fraternity as well as the physiotherapy fraternity, but this theory could not able to explain all the pain behaviors of the patients by using this model. Next, these are the other theories which I mentioned, the specific theory. Each and every stimulus, no, they have their own receptors. For that pain, also pain stimulus must be there. Then only it can produce pain like that. The next theory is that intensity theory. Okay, beyond some proportion of the intensity, the stimulus becomes painful. Then pattern theory, it is the combination of stimuli. 1 plus 2 plus 3 is not pain, but 1 plus 3 plus 2 is pain, like that. There are some kind of permutation combinations of sensations may lead to pain, like that. The next theory is that neuromatrix theory of pain. This is also an upgraded model from Melsak only, but this integrates sensory, cognitive, and emotional inputs. Actually, neurometrics theory says that it could able to explain the different centers of the central nervous system, especially like anterior cingulate cortex, hippocampus, and prefrontal cortex, and these kind of important areas. Most probably, we must have studied in physiology that emotional centers and cognitive centers, and they have some kind of role in perceiving the pain, and sometimes they only can create pain based on the memory storage what they are already storing. So without any stimulus also sometimes pain may come. It's like for example, sometimes fire alarm, no, it may give alarm that there is a fire despite there is no fire, like that. Sometimes these kind of slips may happen from the higher centers, and that may lead to some kind of pain despite there is a tissue injury. That is the neuromatrix theory of pain. Next slide. Then the biopsychosocial model by Angel, even Angel, and they talk about the role of other factors. All we know that the biological factors, tissue injury, damage, cytokine release, and perception through the receptors. All those things already we studied. But they are telling that apart from those factors, biological factors, there are some psychological factors within the individual, as well as the social factors from where and the particular the individual, the patients, pain patients, they live, their work setup, their cultural setup, their age factors, gender factors. A lot of things they may have a very good role in modifying, mediating the pains. So the causative factor may be biological, but the mediators, moderators, and as well as extraneous factors may be present with the psychosocial aspect of the human being. So this theory implicate that we should have a comprehensive assessment and patient-centered care in physiotherapy practice. Next, next slide, please.
Yes, sir.
Hello. Yeah.
Yes,
Next
I'm
slide,
moving
please.
it. Just yeah.
Yeah. In that model, the cognitive behavioral theory, that is CEB theory, like that, cognitive, emotion, and behavior theories. Okay, when you consider chronic pain, which is persistent for more than 3 months to many years, focuses on a lot of thought process, that is maladaptive thought process. We call it as distorted thinking patterns. Okay, catastrophe or depression, anger, anxiety, fear. Okay, because of that, the individual adapt some kind of behaviors like avoidance behavior and acceptance behaviors, withdrawal behaviors, or overcompensation. These kind of behaviors also may contribute to the longevity of the pain, which is persistent and consistent for a long time. So it's always very important to understand the belief pattern of the individual and how they experience pain, how we can assess and do something for those aspects, changing the cognition and behavior that may contribute to reduction of pain in chronic pain patients. Next slide, please. As all we know that we must have heard about the fear avoidance model. This says that we first experience pain, then we develop a fear of pain. Because of that, we adapt some behaviors. These are called avoidance behavior. If I don't do these things, okay, or for example, if we accept some behaviors like if you take more rest, if I don't sit on the floor, I will not get pain like that. So they may get some activity oriented avoidance, as well as they accept some kind of under activity. Okay, that leads to disuse and disability. That in turn makes a cycle, and that produces the pain furthermore. Okay, this fear induced pain cycle develops within the individual. So we have to find out and what kind of avoidance behaviors they have, how to break that, how to assess, and how to evaluate, and how to make provisions in our management. So understanding this theory and the concepts of fair avoidance behavior, that may be very helpful for physiotherapists to deal with their patients with chronic pain. For example, one of the important things is graded exposure. So the graded exposure is a technically sound method which they use in psychology area to treat anxiety, depressions. The same kind of thing can be used for treating the fear avoidance model-oriented pain management in physiotherapy patients suffering from chronic musculoskeletal pain. Next slide. This central sensitization. What is central sensitization? For example, if at all we get injury, there is a tissue damage. For example, I get hurt on my wrist. Immediately, I get a pain around the wrist. All we know that there is some injury. Because of the injury, there are some cytokines released. The cytokines send the signals to the spinal cord and the central nervous system. The brain perceives the pain, and this is called peripheral sensitization. But there is a healing process. The tissue heals, gradually heals. Even after 3 4 months, also I have the same kind of pain in the wrist, and more than the wrist, above, near the elbow, near the neck. Also, I may get pain. This is called a central sensitization. How that happens? It happens in two ways. One is called hyperalgesia, and one is called allodynia. Hyperalgesia is that it is hyper means more, algesia means pain. So, whatever the stimulus intensity, even the less stimulus intensity can produce more pain. Okay, so the nociceptive strength is less, but nociceptive perception is very high. It is called hyperalgesia. This particular thing happens due to the agitation of the nervous system, spinal cord, above the spinal cord, and all the other centers. No, they get agitated. It is like wrong alarm. Because of that, even small nociceptive, very less nociceptive strength stimulus can produce pain. The next one is called allodynia. Allo means anything which cannot produce pain. For example, a pressure cannot produce pain. A touch cannot produce pain. But in this case, simple touch, deep touch, pressure, change in the temperature, weather, that also may lead to pain perception in the chronic musculoskeletal pain patients. So these two things are the cornerstones of central sensitization phenomenon. And this particular central sensitization phenomenon should be assessed and evaluated. There are some physical methods like quantitative sensory testing methods, algometer can be used, or we can use some central sensitization inventory. Through that, we can come to know whether the patient is centrally sensitized or not. If they are centrally sensitized, so we have to change the aspect of dealing those kind of patients. In physiotherapy practice, almost 1/3 to 1/5 of the patients may be suffering from central sensitization, which we normally miss, and we could not able to treat them in a in better positions. So the patient satisfaction level is low. Even we also feel that we could not able to satisfy the patient to the level, to the core. The second picture, if you see, for that the evidence is that when there is only pain peripheral sensitization, the first brain picture you can see. The second one, the pain with central sensitization. Actually, there are strong evidence supporting that the brain structures, the brain areas, they are structurally and functionally changing during pain central sensitization. So patients with pain more than 3 months to many years, definitely they have some structural and functional changes in these localities of the brain, and this is proven by a lot of MRI studies, functional MRI studies. They could able to explain why patients they have widespread pain and pain of disproportionate this one. Okay, so these kind of things can be easily explained through this central sensitization phenomenon. Next slide, please. So to put everything into the theory has been changed. The models have been changed from simple tissue injury to multifactorial. So definitely, but the physiotherapy also should change from a simple exercise therapy and electrotherapy modality based on gate control theory to a multifaceted integrated approach we have to adapt. Okay, let me talk the second part of the webinar, that is PT practice. So treating a chronic pain is not that easy like treating an acute pain. Okay, nowadays the present evidence, literature evidence says that chronic pain does not come only for old people, people with more than 55 years, 60. No, it comes to all the age groups. Even nowadays we see children also. Children also suffering from. Already I have shared a few PDF with you people. You must have seen one of the PDFs is regarding the chronic pain in children. So any age group it can affect. Okay, even less than 18 also suffering from chronic pain problems. So physiotherapy practice, definitely we are supposed to be more multifactorial and multidimensional. Okay, so we have to think into the other dimensions of physiotherapy, not putting more effort only on the physical component, physical dimension of pain. We have to concentrate on psycho, social, vocational, and other components, as well. It's very important for physiotherapy practice. Next slide. So the biomedical model and biopsychosocial model, which we are supposed to practice, the recent evidences on MSK pain insist more on BPS model than a pure biomedical model when it comes to chronic musculoskeletal pain. Next. In that, but number one thing is that to change all these aspects, one of the important physiotherapy practice which we have to adapt is that the pain neuroscience education. This is one of the important strategy which we are supposed to adapt, learn through continuous physiotherapy education. And we should understand what is the pain neuroscience education, and how pain mechanisms are there in the body, what is the normal physiology, what is the pathology, what happens, okay, what is the role of activities and other things on this particular mechanisms. Okay, you can see the right side. Okay, you are supposed to have some kind of education sessions regarding hyperalgesia, allodynia. Okay, what, how the stress contributes, what happens to the neurobiology in during the central sensitization, what are the roles of fear, catastrophizing, emotional overload to pain. So for these kind of things, no, there are some education literatures, models, and kind of teaching methodologies. Everything is available. Okay, just we have to get mastery in this particular pain neuroscience education. For example, if the, even in assessment also, you have neuro pain education questionnaire is there. You can give that questionnaire, you can come to know that how much the patients are educated regarding the pain. how changing their viewpoints, education that improves the cognitive beliefs, that changes the structural functional attitudes of the higher centers. Okay, all those things are literally proven things. Recent evidence are highly supporting that. There are in the last decade, no, huge and enormous evidence are present in the literature. So definitely, physiotherapists, we are supposed to know how to deliver, how to learn pain neuroscience education, and how to deliver to our patient community in our day-to-day practice. There are immense resources are available. Just you type PNE or NPE. Okay, there are immense resources are available on the internet for children, for adult. Okay, even applications are available. Mobile applications are available. First, one important thing is that we are supposed to know that, accept that, and we should try to implement that in our physiotherapy practice. So one of the important key point of the session is that better have upgraded knowledge regarding pain neuroscience education. Next slide, please. Then self-efficacy and coping. This is also very important to empower the individual to manage pain. Okay, normally physiotherapists, no, based on the biomedical model, we try to fix it. We play the role of reductionist. But when it comes to chronic pain, musculoskeletal pain, no, that reductionist approach does not work. So if you are restricted to limited to your electrotherapy and exercise therapy modalities, which we apply passively, only quantitatively we give importance based on the number of counts and number of days, and more you do, it's good, like that. These kind of things, no, it may be having some limitations, this kind of approaches. So definitely we should look into the person and make the person, the individual, the patient responsible for his pain and modulating the pain, because without the cognition and emotional involvement, it's very difficult to treat the pain in a passive manner. We can understand the perceived importance, self-efficacy, and the patients are supposed to be ready to change. That's very, very important. So a patient coming and lying down on the couch, no, may not be enough for managing the pain. So if you see the right side, there are a lot of self-management behaviors. Okay, it starts with the exercise. Even exercise, they have to involve and they have to understand, they have to modify the thing. So simple, what do you call, method from ACSM may not be very helpful. So we have to adjust that. Pit principle may not work with the chronic pain patients. So we need a lot of adjustments like pacing, relaxations, ignoring pain, avoid guarding, avoid pain catastrophe. है all these kind of things, no, we have to give some kind of education, self management strategies, whether they follow it. There are a lot of logs and monitoring tools are available in the net. Okay, which we can download it. For example, we can make them doing their activity, what do you call, leisure activities, more serious, and it should be noted, it should be practiced. Okay, how they cope up with their sleep, what is their normal routine. So all these things should be really monitored, and it should be evaluated before that. Then we have to make a plan which is very much conducive for both the patient as well as the therapist. And we can monitor through using the apps and the gadgets, and we can take the support of many what do you call, online tools to support things, because nowadays patients may be very much interested to do the things through their gadgets. So we can use the Android phone and other facilities, no, to make all these things to happen. So self management strategies and implementing the self managing strategies effectively. Okay, we are on the background of the particular thing. So but we should make them understand that 80% you are only whole and soul responsible for your pain. Until unless you don't change, it's not possible. to change these kind of things. No, we have to do it in a practical manner. I'm not talking about only giving advices, which we have to do it with a proper understanding. That is what is very important in improving the self efficacy and coping. Next slide, please. For example, if you see activity pacing from the picture, this is called boom bust cycle for the chronic pain. What this particular picture indicates that to the audience is that normally we have more of a interest doing the things beyond our limit. Okay, so we think that I am capable. So once they do that, they get into pain immediately, and there will be cognitive distortion. As I did this, I got pain. So let me not do this. Then they don't do that. Suddenly they get one the other activity which they are supposed to do. They do it. Always they overdo only. So then immediately if there is more pain, they stop that activity. So either they have their problem is that they try to overdo it, they suffer from pain, immediately they come to underdoing. That is the way gradually once they progress, their level, the activity level reduces to the lowest extent. Even a small simple activity is very painful, then they stop doing that activity. That is called avoidance behavior. So this activity boom bust chronic pain cycle should be broken down by our practice. For that, we use one method called activity pacing. This activity pacing, there are a lot of components. Uh, Components like how they adjust, consistency, what do you call planning, preparation, whether they accept. So if you see that each and every activity in day-to-day activity, some people may be interested in some activity, some people they are very much bound to do that activity, they don't have any other scope like that. So what happens, we have to find out. For that and all, you have some questionnaires, activity pacing questionnaire, activity engagement questionnaire, perceiving the overactivity questionnaire. These kind of things, no, we can implement, and we can find out what are the important areas they have problems, and how we can modify those areas. Okay, so for this also there are a lot of resources available in the net. Just you type activity pacing and the components, principles. Okay, how to implement that practically in our sessions. That is what is very important. So don't say that you break your activity. That is advice. I'm not talking about the advice, which should be practiced, evaluated. Then it should be practiced with logs and monitoring and tools. Then again you have to reassess. Then you have to show it to the individual that you are improving in that way. So the practice should be outcome based practice. It should not be advice based practice. So it should not be solution based. It should be outcome based. Okay. Next slide, please. Apart from that, the social environmental context, this implementing this, you need some kind of more strong efforts in terms of communication to the patient. Normally our communication may be very brief, or with some kind of shortcomings. To understand the work culture and the family effect, and then their society where they live, that also can impact the people, the peer groups, and the friends. Okay, or the practitioners even. Okay, we may be having some kind of half-cooked ideas, or ideas with some kind of shortcomings, and blind advices, do's and don'ts. Definitely these kind of things may have some impact on pain perception and behavior. If you want to share my experience, one patient told he was wearing the lumbar belt for more than 7 years. His age was only 37. Somewhere, sometime, point of time, the doctor prescribed this one belt. It will save you from back pain. He started using it for 7 years. Okay, so these kind of social environmental context may be having some kind of impact in the pain, perception of pain, productive movement behaviors, avoidance movement behaviors, relying more on rest, sitting ideally at home. You understand these kind of things definitely works. or social pressure, the explanation what they get from the friend circle and peer groups regarding pain. There are a lot of pain descriptions, why pain comes, how treatment works. There are a lot of myths as well as wrong ideas, concepts are they're everywhere. That can influence the patient's pain perception. So definitely we have to have some good understanding of that, especially fear, poor sleep patterns. Understanding these, no, that may improve more of chronic pain. Next slide. So the integrative model, which I could have, I try to insist in this webinar is that the biopsychosocial model, cognitive behavioral theory model, neuromatrix theory, all these theories you have to mix it up, and you should learn or upgrade your skills in evaluating these aspects, and how to make changes in physiotherapy practice, and what are the tools and other resources available at present times, and how I will implement my physiotherapy sessions, and I will convert my physiotherapy sessions into a fixing session to a tailor-made personalized active physiotherapy sessions. Okay, that makes more sense. So our physiotherapy session should be multi-dimensional, and it should have the assessment evaluation of not only physical, psychological, social, occasional assessments, and even cognitive, emotional evaluations. Therapists should understand, and they have to have more knowledge regarding anxiety, depression, and chronic pain, psychosocial factors. There are enormous what do you call resources available in the internet. The physiotherapist can do some kind of weekly, monthly certificate courses, small what do you call online courses. They can upgrade and update their knowledge in this particular area to manage pain effectively, and you can satisfy your patients. So make your sessions mostly multidimensional than simple fixing sessions. Next slide. So you have one assessment framework. It's very important. So the simple soap notes may not be effective in your assessment. To give some example, I'm giving you, for example, you may use fear avoidance behavior questionnaire, FABQ, FACS, and you can use central sensitization inventory, pain catastrophic scale, pain disability index, quality of life also you have to measure, pain self efficacy questionnaire. Okay, quantitative sensory testing to test through algometer, using algometers. Okay, and emotional component assessment like psychological distress assessments in pain. Like that, you may have to use some of the psychosocial domain scales and evaluation materials to know about more about chronic pain. Then your sessions will become little more multi-dimensional. Next slide. The management implications: try to adapt neurophysiological education, exercise, prescribe exercise, don't strictly follow only fit principles when it comes to chronic pain. Try to modify it, try to adapt according to the individual who you are treating, based on the age group, based on their abilities, capabilities, and their preferences. You can make some changes, then have some in-depth knowledge in activity pacing, like that. Then you may have to use some cognitive behavioral therapy principle, that is how to make distorted cognitions to normal cognition. Okay, there are some few methods gradually you can learn and you can implement in your communication, and that may really having good impact on the patient's pain perceptions. And then goal setting, for example, smart goals. You make your goals always specific, measurable, attainable, relevant, and time bound. For example, you cannot simply say that do walking every day. So you can make it how specific, weekly 3 days. How you are going to measure? I'm going to use my number of steps calculated by the Google, whether it is achievable. If it is not achievable, how you can achieve that? I have to go alone walking, so I'm afraid. If I get a friend, then you have to give the idea, make a friend like this, like that. Somehow you make it achievable and relevant and realistic. It should happen really. It should not be only in the plan. It should happen. So you have to give a log, Monday, Tuesday, Thursday morning, this much time walked. So weekly feedback you have to take. Okay, and then achieve the time. For example, first week you achieved only 1 hour walking. Second week my goal is 1.5 hours. Like that, periodically you have to get the feedback, you have to monitor with the logs and everything. All those materials are available in the net resources free of cost, whatever I'm telling. Okay, you can use that and you can make it more realistic than only it's a simple advice. Okay, next slide. And the evidence and guidelines also supports whatever I talked till now. For example, nice guidelines from UK International Association for Study of Pain, EASP, and WHO frameworks. All are encouraging personalized theory informed care. That means what you are doing, that theory also you have to some extent explain to the patient. Otherwise, managing chronic pain patients is very difficult. And one more thing, adult learning is somewhat different from childhood learning. So adult learning theory, you have to understand when you teach something, when you educate something, you have to know the psychological background or concept strategies of adult learning. So it's not very easy that you give one advice immediately one adult will start following it. Definitely he will not do. So you should know the basic principles of learning, adult learning. Just there are some theories which we have to upgrade in our knowledge. That may be very helpful how to handle the adult patients to change. Otherwise, they will not be conducive to your management strategies. Okay, simply they will come for your equipment and other modalities, and every day they will be complaining about the same pain. Next. This is the evidence one. This is in 2013. The desirable characteristics of national pain strategy. Each country should adapt this. Okay, for example, basic signs of pain, assessment needs of a person in pain. Okay, biopsychosocial approach, multidisciplinary focus, timely. So everyone should get immediate access to care. That's very important. Then emphasis on self care. Okay, involve family and caregivers, feedback from the patient, measure the quality of life. Okay, and do more research. These are all the important what do you call strategies should be adapted by a country. Okay, that is what is given by this guideline in 2030. Okay, I have explained a few things, whatever in the red, no, I have explained you. So in terms of tools, resources, that's what I was telling. Okay, the first section A is for health professionals. Definitely, we have to improve our knowledge regarding chronic pain and theory of chronic pain, understanding of chronic pain should be improved. Then we have to teach that to our patient community also. Okay, so we cannot be only a reductionist. Next slide. If you see this one, no, these strategies, whatever mentioned by the IASP, whether they are followed by the countries. If you see, our India is here. Okay, we have only access to medicine in green. Okay, right? Uh, all other things are either red or not done. So these many areas are pending. Okay, first area itself, pain research is somewhat deficit. Then pain education, understanding pain and all. No, we are using the old strategies. Okay, you can see that. So we have a lot of potential areas. The quality of life we don't measure only. We only use vast scale or NPRS. Beyond that, we don't go for pain assessment. So it's we have to improve in these many areas to make our practice more multidimensional. So there is a lot of scope for a country like India to implement each and everything. For that, first we as a health professionals we have to learn what is left out there. and how other countries are improving in their pain management strategies. What are the policies? Okay, gradually we have to do from our side, and we have to span it out in all the areas. See to that in future there are policies being adapted by the governments, state and central government, and the pain management practice improves. Okay, this should be our aim. So each one of our contribution, pain education, pain research, and all we can contribute. Okay, all the aspects we try to implement in our day-to-day practice, and that may improve the patient awareness, public awareness, and definitely things will change gradually. Okay, this is the only way to get policies for the future practice, for the future young budding physiotherapists. Next slide. This is the second evidence back skills training program. This is by approved by British Psychological Society. If you want, the people can join and do. I think it's a 6 weeks or 8 weeks program, online program. It's based on biopsychosocial model, and it is called BEST program. Back skills. It's mainly for back pain. How to use this uh, BPS model of practice in managing chronic back pain. Next slide. This is the nice guideline. If you put that in Google, no, you will get it. And the core point only I have written. We are supposed to improve. Internationally, they are telling it was in 2020. We have to improve good communication with the uh, patients to experience better experience managing chronic pain patients. So improving communication is one important thing for what do you call physiotherapist to become a rationalistic physiotherapist. So there are a lot of trainings are available online. You can do better if you communicate more, and if you evaluate more, if you try to span out to all the dimensions of care, then definitely your understanding of pain will improve. Then your care also will improve, and you can make a personalized care. So communication abilities should be improved by the healthcare professionals. So look for more CPEs and CPDs regarding that, and attend that, and then access the reliable resources. Okay, next slide. I think some
So
problem.
I think some glitch. I'll reshare.
Yeah, I think only one slide is there. That's it. Done.
So just a minute.
Yeah. Okay. Next slide. Yeah. Take home message is that understand the theoretical understanding, do with the reasoning, and plan your care for individuals. Okay, don't make it as a general protocol for everyone. Each and every individual is different. Then always look for improved outcomes. Don't depend on solutions. Always you have to look for the outcomes. For example, selecting a modality is a solution. After selecting the modality, what happened to the aspects of care, that is called outcome. If the outcome is not changing, it is meaningless to adapt solutions. Okay, so always your care should be outcome based, not solution based. Next slide. Okay, it is a simple thing. I will explain chaos theory. For example, if you can see that the picture shows that there is a car, we think that the important part of the car is that the engine. But despite engine is in proper condition, if you don't have proper wheels, okay, if the nuts and bolts are not working properly, okay, you cannot drive out. The same thing, even small things are very important. Gradually building thing, no, that will work. That is what is written, that is called chaos theory in simple thing. Small reactive changes you make, enlight through the integration of new information, try to give some knowledge about what is pain to the patient. That's very important. So pain neuroscience education, explaining the things to patients, they have a very great role. Okay, then change in the belief system, that is also very important. Cognitive changes, so cognitive and education, then small efforts like starting a 10 minutes of walking every day, or setting the sleep time. Okay, and setting the time for relaxation, setting a fixed time for having a chat with friends, like that. These kind of small changes will make a very big effect in the pain perception and pain reduction. Next year. Okay, this was the conclusion. Try to adapt biopsychosocial, this one. If you want, you can read my article. It's a simple editorial only, maybe 3 pages, not more than that. If you read, you will get a conclusive idea regarding how to deal with the persistent musculoskeletal pain. Thank you very much for your patience. It's done from my end. Back to Dr. Anzala.
Thank you so much, sir, for that deeply insightful session. It was really a pleasure to have such wonderful knowledge about chronic pain. We'll now open the floor for questions. So, participants, if you have any question, please use the raise your hand feature or you may share it through the chat box.
Even if they type, you can just read it
Yeah,
out.
yeah, yes, sir. If they can, if you want, you can type in the chat box.
Thangamani sir, I have a question, sir.
Yes.
Yes, sir. Sir, can you share for the people who have participated right now? There are many who I know who are not aware about how to start working on with the BPS approach, particularly in a holistic care.
Mm.
So, can you share some available resources in online to start learning chronic pain, particularly pain neuroscience and everything, sir? Can you share some best, like as you said, best protocol, nice guidelines, sir? Can you share some other which is very useful for our participants, sir?
Share means you would like to share it
You,
in WhatsApp.
from your words, sir, from your words, which is very good. You can go for that. Any good programs which you saw in online, you can share to the participants, sir.
First one, they can join that best skill program. It's an online free program. Okay, but it is a non-credit program. Maybe for I think 36-40 hours. It is from Celebrity Psychological Association. Okay, and they can learn the things in their own pace. There is no ceiling. They have to finish it before these many weeks. Not like that. So it's very easy and it's online program. I think it is in. Yeah, other than that, they can use Future Learn. I think Future Learn. They can go and get this program. Same like and the similar programs are available in Coursera as well. That is from US based. From there also they can do online certificate courses regarding pain management, chronic pain management. I think there is one 12 weeks program is there by Dr. Frickton, like that. Chronic pain management. The program name itself that only. That is also free only. Okay. Even if Udemy also some programs are there, and they can have some programs for understanding anxiety, depression in chronic pain, and exercise prescription, neurobiology in chronic pain. Like that, many courses are available with videos and pictures and with lively examples. So 1 hour may not be enough. Just simply I only touched. They have to update all this knowledge, then only they can deliver. And one more thing, it is not like a technique. Every technique, no, in the name you should not think that it should be a physical technique of a passive technique. That's what I mean to say, that we cannot fix some pains. It is not generalized. So if you are in that mood of learning a technique with the hands on therapy, and doing some pushing and pulling in some area, out of three patients, you may not be treating two patients. Only one patient you can treat through that, what do you call, hands on. These other things, no, you need some kind of understanding and approach strategies. Simply saying strategies are not a simple techniques. It should be a holistic approach, then only and they can go. So they may use Coursera, FutureLearn, Udemy. There are plenty of free courses they can do during their student life itself. They can start doing it. And understanding theories of pain, there are a lot of free courses, 2 hours, 5 hours, 6 hours courses are there. They may easily understand what is pain. So from our books, old books, what we learn about pain is somewhat very fundamental, and it is a reductionist approach, but it does not work in that way.
Thank you, sir. Thank you. Sir, I would like to add one more also what you said. I have recently undergone a course called Evolve, sir. Evolve, which has been run by Peter O'Sullivan.
Yeah.
That course was, Evolve was really good for it. It gives me a good idea about cognitive functional therapy, CFT model.
See,
I'll also share, sir.
yes.
Participants already, what Dr. Thangamani sir shared, I have shared in the text. Hansala, we have one more question, madam.
Yes, sir.
Dr.
Yes,
Hansala.
sir. Yes, sir. We have a question by Krishna Taylor, and she's written that with increasing emphasis on avoiding over medicalization, how should physiotherapists screen for red flags without over referring patients with chronic back pain for imaging?
The thing is that first of all, pain should not be considered. For example, you are getting a back pain. Normally, budding therapists may think that back pain is for physiotherapists. I am the master in that. This patient is for me. Not like that. It's fine. 90% of the back pains are not dangerous, but 10% of the back pains are dangerous. But we should have the skill to evaluate those 10 percentage of the patients. Otherwise we may be what do you call, more light will come on us, and those things will come on newspaper and social media, that physiotherapists are doing this, doing that, like that. So always, no, compared to what we do, don'ts is very important. We should not end up with some kind of dangerous issues or problems which may be spoiling the professional reputation. So back pain, as far as book is concerned, it is a simple. Back pain is very simple, easy to treat. It is a 5 mark question. It is not so. There are a lot of things we have to concentrate, we have to focus, and we have to be more serious about how to evaluate and eliminate those. So deleting is very important. We should not touch any serious problems, knowing that I'm a physiotherapist, I can handle. So for that, we have to have all these kind of focuses. We can avoid that, number one. Number two, when you treat that 90% of the back pain patients, each and every patient should be categorized. That's very important. That 90 patients are not same. They are not of the same age, same causative factor, same mediating factor, same moderating factor. It is not though. Each and every patient may be categorized. Whether the patient comes in acute category, or with the tissue damage, without tissue damage, or to what extent the central sensitization is there, what are the factors, like that. So each and every patient should be categorized by you. In that, out of the 90 patients, almost 50% will be very much successful. Just like that, simply you follow your regular physiotherapy, it will be done. But rest of the 50% of the patients in that 90 categories, no, they will be having different. That's why we are telling, to handle those kind of patients, you have to have some kind of in-depth knowledge. Okay, I gone through one what do you call, one social media sharing. One physiotherapist comment. was like that. I treat three patients. In that one patient back pain, I don't know how they became all right. The second patient, I think that I treated, they got all right. That patient, I don't know why they are not getting all right. So each and every patient is different. So whatever the patient, they become good or pain is relieved. For most of the patient, you don't know how it worked. For one third of the patient, you don't know why the pain is not going, why it's not getting relieved. You got my point, what I'm doing. So this is the way it is there. So you have to categorize those patients. We have to put different knowledge for the to conquer in that area. So definitely failures are there in back pain. Even though back pain is the commonest condition, we have more to do in that particular area. Anything else?
Any further questions? Any further questions? So I think there are no questions for now.
Okay.
If there are any questions, I think we can continue in the WhatsApp group if there's
Yes,
any
yes,
question,
for
right?
sure. Yeah.
So thank you for all the thoughtful questions and thank you, sir, for addressing each of the questions with such clarity. So as we conclude, I extend heartfelt gratitude to our esteemed speaker, Dr. Thangamani, sir, for an enlightening session that redefined how we perceive and approach pain. A sincere thank you to Dr. Alagappan Thiagarajan, sir, for his constant support, his mentorship and vision, and to all the participants for being the spirit of this initiative. We invite you to stay connected with Rehab Dialogue. Yeah, you can. You can follow us on our social media handles like Instagram for community highlights. You can follow us on YouTube for the recorded sessions and more thought-provoking collaborative efforts. You can also keep into our WhatsApp group for further communication regarding the upcoming events to be taking place. Also, please don't forget to fill out the feedback form, which is shared in the chat. I'd really appreciate if you could do it before 5 p.m. today, and that will help us, proceeding with the e-certificates. So, with that, this is just the beginning, and there are many more dialogues, collaborations, and ideas up on the horizon. So, until then, keep learning, keep questioning, and keep moving, because in the world of rehabilitation, every movement begins with a thought. So, thank you, everyone. Have a wonderful day ahead. Thank you, sir. Thank you for joining.